think that's an area that's a real need. So I was really pleased that the ICB CCG was able to recognize the importance. You would note all the presenters actually are local people, and that's what I wanted to keep, is to develop the local faculty. We had an introductory session a couple of days ago on the whole program. Yesterday was an excellent session by some really good presenter on CKD. It's all recorded. And today, again, a really important topic, which is diabetes. And I can tell by the number of people that have signed up that that's an area people really feel that there is a need. So I hope you enjoy today's sessions. Just a bit of housekeeping. So I'm going to keep an eye on the chat function. So any questions, please put them there. I'll see if I can disturb the presenter, or we can save them to the end. Also, please, again, a big plea. I don't know, at every meeting, I have to say it at least 2 or 3 times. Please turn your mics off. Please turn your mics off. So please turn your mics off. With that, I'm going to ask if the presenters could introduce themselves, starting with Adil, please.
Thank you, Dr. Sood. I'm Adil Ansari, GP in Barking, interest in diabetes and gypsy, working in Barking and Dagenham, and the clinical education lead for my PCN. Thank you, Dr. Sood.
Thank you very much, Adil. Imran?
I'm a clinical pharmacist with a specialist interest in diabetes, working at Ilford Medical Centre. I'm also part of the NEL Medicines Management team. Thank you.
And actually also training a faculty member now, Imran. Don't forget that. And Said, please.
Hi, I'm Said Raza. I'm a GP in Seven Kings. I'm also the educational lead for Seven Kings PCN. I've finished my postgraduate diploma in diabetes. That's why Jyoti has asked me to join the team today.
Thank you very much. So we will go through, Said will actually go through the diagnoses. Then we will move on to the medication, which will be covered by Adil. And lastly will be the local guidelines and reference to the NICE guidelines and some case studies by Imran. So I do hope you enjoy. But keep those questions coming in the chat function. So with that, I'll hand over to Said. Thank you, Said.
Thank you, Jyoti. I have been given the task of I think it's the boring bits before the actual thing that everybody has come in here for to discuss the treatments and case reviews. So I will be very quick, very brief, and we'll quickly move on through the types of diabetes and how to diagnose it. So first of all, who to test? Basically, we see lots of patients every day. So who do we need to test if we are suspecting? Obviously, the first ones are they're symptomatic. If they're coming in with polyphagia, polydipsia, polyuria, we need to do the test. On annual health checks, we can pick up as we do their HbA1cs as well. Also, some people are trickling in from they have done their risk assessment scores for diabetes. One of the risk scores are on the Diabetes UK, and there are other IT tools available online. People are doing that, and they're coming in asking for that. We're getting that as well. People with risk factors, with family history, obesity, there also needs to be monitored. Gestational diabetes is a very significant aspect which we should be following up after they have delivered. One of the things which I was intrigued about this fact that 50% of the women with gestational diabetes go on to develop type 2 diabetes. So we need to be very aware of that. Polycystic ovarian syndrome. Again, this was an interesting fact that more than half of the women with polycystic ovarian syndrome develop type 2 diabetes by the age of 40. Also, ethnicity we need to keep an eye on, especially our population, which we see on regular basis. People from Black, African, Caribbean, Southeast Asian backgrounds, they are at higher risk of developing diabetes, especially type 2 diabetes. Low birth weight, again, there is studies about the low birth weight indicates sometimes there is a relative risk of developing type 2 diabetes. Patients who are on various medications, we also need to be, obviously when we do medication reviews, we do check blood tests, so we can keep an eye on that as well, like medications like corticosteroids, thiazide, diuretics, beta blockers, antipsychotics, etc. People with metabolic syndrome, fatty liver, inactive lifestyle, diet, all these things are the people we should be keeping an eye on. While, can we get to the next slide, please? Types of diabetes, I've just mentioned the most important ones, which we need to be aware of, basically, and we'll focus on type 2. Type 1 diabetes, type 2 diabetes, latent autoimmune diabetes in adults called LADA, monogenic diabetes, gestational diabetes, and type 3. We will discuss this in the next slide, please. There was so many different types of classification. Can we go to next slide, please? So there were different types of information available, and different type people has classified type 1, type 1A, type 2, type 3, A, B, C, different types. But what I found interesting was, sorry, can you go slide back up one slide, please?
Femi, can we go back to the slide, please? The previous slide?
Previous slide, please. So this is, no, tell me the next one. So yes, this one, please, thank you. This is where I thought if we keep all these in this format so that we can compare all different types, and this will help us remember all these things. So what I've done is we've mentioned type 1 diabetes, and then type 2 diabetes, and then we can compare with the other types in the same categories, based on their pathophysiology and diagnosis, age of diagnosis, weight. So we'll compare it one by one. So in type 1 diabetes, main thing is, obviously we know, all of you know, that autoimmune destruction of the pancreatic beta cells by the antibodies. Autoantibodies, there are mainly 4 types of antibodies, which are GAD65, ICA, and I won't bore you with those, but just as a main concept, it's just autoantibodies destruct the pancreatic cells, and there is no insulin. Basically, deficiency of insulin is the main thing. Whereas in type 2 diabetes, as everybody knows, that it's insulin resistance along with the relative insulin deficiencies. So age of diagnosis in type 1 and type 2, obviously in type 1 is usually juvenile or less than 25 years of age. Type 2 diabetes, traditionally it was considered that it was in adults, but now any age can have type 2 diabetes. And I won't bore you with all these things. We'll just go to the main bits where the insulin and C-peptide and then pancreatic antibodies. We'll just discuss these. You can have a sight on the rest. So main thing is pancreatic antibodies are present in type 1 and LADA, and they are absent in type 2, monogenic diabetes, MODI, gestational diabetes, and type 3 diabetes. They are all absent. So we just need to be aware of that. Same with we will also need to insulin requirements in type 1, and then it's variable in the others, basically. So this is, I think, I know it's a very busy slide, but basically we just need to compare these two main things. And then we need to discuss a little bit about LADA, slow onset type 1 diabetes, latent autoimmune diabetes in adults, basically. So again, the information is there. So I wouldn't bore you with all this information. Monogenic diabetes is the genetic mutation leading to diabetes. It's maturity onset diabetes of the young. It's called MODY. MODY, the onset is often between the 2nd and the 5th decades, usually less than 45 years of the age, we see this. In this one, the family history is quite important. There is a strong correlation of the family history of diabetes. There will be a history suggesting my father, grandfather, they all had similar sort of presentation of diabetes. Gestational diabetes, we can, you know, that obviously we'll come to the diagnosis in the next slide. This one is where obviously during the pregnancy, there is impaired glucose tolerance. And now we'll come to the criteria in a minute. That definitely it needs to be monitored. And then as we mentioned that after giving birth, there is a risk of developing diabetes, type 2 diabetes in the long run. Type 3C diabetes is the pancreatic disruption of the function of the pancreas is disturbed because of the diseases like pancreatitis. Cystic fibrosis, again, causing disruption of the pancreas function, causing this thing. Hemochromatosis is another thing, and pancreatic cancer is another condition where you can see these ones. So I'll leave this slide. It's quite a busy slide. And then can we move on to the next slide, please? So the next slide is the diagnostic criteria. Mainly we'll be focusing on type 2. Obviously pre-diabetes, as you all know, the NICE criteria is 40, the HbA1c level of 42 to 47 is considered as pre-diabetes. Obviously we all see this on daily basis, and we start referring, and diet and lifestyle modification starts at this level, keeping them under control. Then diabetes, in order to diagnose diabetes, NICE has given us these criteria that fasting plasma glucose greater than 7 millimole on 2 separate occasions, and HbA1c greater than 48 on 2 separate occasions is considered as a diagnostic criteria for type 2 diabetes. Gestational diabetes is where we have the oral glucose tolerance test, in which the fasting level is greater than 5.1. Any single blood sugar level above these levels is diagnostic of the gestational diabetes. So fasting 1 hour is more than 10, and at 2 hours, it's more than 8.5. These are the diagnostic criteria of the gestational diabetes. Can we go to the next slide, please? And as we can see, it has changed from 2015 to the latest guidelines have changed. So again, this is a busy slide. What do we do at the diagnosis? When there is a diagnosis of diabetes, there is a list of things, like we have to explain the diagnosis. We need to give enough time to the patient to understand what, if they understand, if they are educated, then obviously they'll be able to manage, especially in our population where the language barrier. So I won't bore you with all these. We do this on daily basis. All of us are clinicians, and we see this in our cough templates for diabetes. It's BMI, smoking, alcohol, refer if appropriate. Structured education is very important if you can refer. Eye screening, foot checks, regular bloods, urine ACR, contraception. Obviously, when there is contraception, folic acid is really required for the development of the baby, to avoid any neural defects. Driving, they need to be aware of when to inform the DVLA and who should be informing the DVLA. There is one slide at the end we cover that. Also, free scripts medication exemption form. Also, because it's a long-term condition, depression should be assessed at that point. Vaccination, curious, all these signposting them to the diabetes.org.uk. There's huge resources and huge amount of support there. And obviously we arrange regular follow-ups until they are stabilized, and then every year we do that. Can we go to the next slide, please? Again, on annual review, this is not much different to the previously what we've just discussed at the diagnosis. So we do all these things. But obviously, if somebody's on the medications, we have to just add on the side effects, self-monitoring, all these things, or for the medications, and again, arrange the follow-ups. Next slide, please. Yes, while monitoring the diabetes, HbA1c is the main thing that we need to monitor. But as the most important aspect is individualized care is the key in monitoring diabetes. So not everybody will be giving the same results with the same medication. So their circumstances will be different, their lifestyle will be different, their working pattern will be different. So there will be a difference. So, but however, we have to, one criteria we have is HbA1c, that we can at least bring the HbA1c level to these. So if somebody is only on diet controlled, they should aim for at least HbA1c of 48. So again, if they're on a single drug, again, 48 is a reasonable target to set for them. And then if drug treatment associated with hypoglycemia, such as sulfonylurea, 43 is the second criteria that we can maintain. Obviously, if we try to reinforce more control, then obviously there is the risk of hypoglycemia as well. Can we move on to the next slide, please? Then again, also we need to monitor cholesterol in diabetic patients. So if they do not have cardiovascular disease, we can maintain the cholesterol by starting at atorvastatin 20 milligrams. The person who's aged 84 and younger, if their estimated CVD score is 10% or more. And obviously we know that if they have established cardiovascular disease, they will come to us with the atorvastatin 80 milligrams. So the aim is for reducing the 40% of non-HDL cholesterol. Next slide, please. Foot care, again, monitoring the diabetes. Foot care is a very important aspect if we want to avoid amputations. So we have to look for any history about previous ulcers or amputations, symptoms of claudication, numbness, smoking, nail cutting techniques, and do they know how to examine their feet? Are they aware of what to look for, how to look for sensations and all the things. Also, whenever they come to us, we have to look for, our nurses usually do that as well, foot checks on regular basis. We all know that. So in this examination, we should include nails, skin, arches, pulses, sensation, shoes, and any deformity and ankle brachial pressure. We can, on examination, we can stratify this into low, moderate, or high risk and refer accordingly, as mentioned here. So I think we're all aware of these things. Next slide, please. Yes, diabetes and driving. Who should be informing the DVLA? I normally give this link of the DVLA to go and see what you have to do. Obviously, people who are treated on insulin, whether it's a car or motorbike or any sort, they have to inform the DVLA if the treatment is lasting over 3 months. And again, there are all instructions about this insulin that can be looked into. And diabetes treated with tablets or non-insulin injections, that again in the instructions from DVLA, it says check with the doctor or the nurse to find out if your treatment means you need to tell DVLA. That can be tricky, but obviously if they are on medications which can give them hypoglycemia, then we need to be telling them to please inform DVLA. Any bus, coach, lorry licenses, they all need to inform DVLA, whether they are on, even if they are on simple tablets or non-insulin injections, they have to inform DVLA. Next slide, please, if there's any. See, so I was very quick, and because I know everybody, most of this was already known to you, you're here for the main chunk, which is the treatment and Imran's case reviews. So I would let Adil to carry on from here. Thank you.
Thank you very much, Saeed. That was really comprehensively covered. I am answering some of the questions as we're moving along and just putting some other sort of comments, if people could just refer to those as well, just in case we run out of time at the end. But with that, Adil, can I bring you in? But just to say, Imran, if you could at some point just cover your experience of LADA diagnosis. I think this is really important, maybe just presenting a case situation when you are doing your. So Adil, with that, please, can I pass it on to you? Thank you.
Thank you, Dr. Saeed. Thank you, and I'm just moving on. So I'll be talking and reviewing the treatment options we have in the management of type 2 diabetes. Next slide. Thank you. Just a reminder, there's a lot of evidence out there that improving glucose control is important. With improving glucose control, we do reduce the risk of both the microvascular and macrovascular complications and the risk of diabetes-related death. I think as a part of every consultation, it's important that we remind patients of, as Saeed mentioned, about what is diabetes, why is diabetes management important, and also important to remind patients of the risk of the complications with poor control. Just with better education, they're more likely to adhere to the treatment and follow advice and better compliance. Next slide. Here's just a reminder that type 2 diabetes is both a mixture of insulin resistance and relative insulin insufficiency, and that with the insulin resistance, weight is a very important factor. With increased weight, obesity and central obesity, the body's insulin resistance increases, and also with enough evidence from studies that as the body's weight improves, the body's insulin resistance improves. Next slide. Again, a reminder that at every consultation, we should address patient education as a starting point, and we should also remind and go and look into the lifestyle, looking at the diet, reviewing the diet, discussing changes, looking at physical activity, and looking at smoking cessation. And that's important that this is all looked at along with medications at each review consultation. Next, please. I'm just going to pause for a few minutes and just maybe you can put them in the chat box or have a think that when we are prescribing medications for diabetes, what is it that you like to know about the medication? What is it that is influencing you with the medications, and what would you want to know about the medication? If you can either just think about it or put some comments in the box, that'd be quite helpful. Any comments, Dr. Sood, in the chat box?
Yeah, so we've got a really good one, CKD, lifestyle, compliance. So really, really good sort of feedback. EGFR, how much HbA1c levels will improve. So all really, really relevant feedback. Adil, you've got a very, very good audience.
So thank you. So we move to the next slide. Next slide, please. For me, when looking at the medications and prescribing them, I'm really interested to know what actually, how does medication help reduce the glucose level? Will it actually help improve the insulin resistance? Will it help with improving the relative insulin insufficiency? Will it help with weight loss? Because we know weight is a really important factor with insulin resistance. Is there a risk of hyperglycemia, which can have implications on their work and their personal life. What are the side effects? What are the contraindications? And as we mentioned, renal impairment is a very important issue. We know that end-stage renal failure is common. In 30% of patients, diabetes is the cause for the end-stage renal failure. Next slide. I'm going to review the medications, discussing the mechanism of actions, the benefits and side effects, starting with the older medications that we had, and some newer medications, but some of them are not new anymore, and they've been used for many years now. Next slide, please. Next slide. I'm sure we all heard of metformin. Metformin is the kind of first medication introduced around the 1950s. It's a biguanide class of drugs. In most guidelines, it is the first line option. How does it help? Well, it helps decrease gluconeogenesis. By doing so, it reduces hepatic glucose production and also reduces the fasting glucose level. It can also help with increasing insulin sensitivity, and by doing so, enhances peripheral glucose uptake. And finally, it also helps by decreasing glucose absorption of glucose from the GI tract. Next, please. Renal and metformin is a really important topic to remember. It is renally cleared. It is excreted in the urine. With renal impairment, metformin can accumulate, and with that, there is a risk of lactic acidosis. It is contraindicated with severe renal impairment. NICE has supported and given some guidance about when to look at metformin, when to start, and the guidance is that actually, if the eGFR is less than 45, do not start metformin. If the patient is already on metformin, and the eGFR drops below 45, start reviewing the dose. And if the eGFR drops below 30, metformin should be stopped. And should be used in caution with hepatic failure, alcoholism states because of the increased risk of lactic acidosis. And we've probably got a lot of radiology forms being rejected, coming back because they're not being completed, along with the renal function, where the metformin is also really important. It's important that metformin is held prior to investigations with IV contrast and dyes, just if there's any renal impairment after the scan. Next slide, please. It has got benefits. It doesn't cause hypoglycemia. It's weight neutral with some weight loss. It has got anti-mitogenic properties, so helping cancer prevention, and it's cardioprotective. Next slide. I'm sure this is all, we're probably aware of this side effect metformin, mostly are GI related, the diarrhea, the abdominal cramps, nausea, vomiting, and flatulence. From experience, we can reduce this by starting at the low dose and building up, letting the patient settle at a lower dose, and when they're settled with symptoms, then increasing up. There is the modified release, slow release formulations that can be used. And also from experience, if tell the patients to take it with food or during the food or immediately after, it does help reduce the side effects. B12 depletion, this is an MRH also been reminded again and again that B12 depletion is reported in patients with the high dose and long-term use of metformin. And therefore patients on metformin are presenting with the possible B12 deficiency symptoms. It's very important to monitor and replace this accordingly. Next, please. Moving on from metformin, the next medication that came out was the sulfonylureas, which again have been out since 1950s. You've got the first, then the second and the third generation SUs. They differ generally in how they eliminated and the half-life of these medications, and the second and third generations having more efficacy compared to the first generation. Next slide, please. Here's just a quick reminder on how sulfonylureas work. They bind onto the SUR receptors on the pancreatic beta cell. By doing so, they inhibit the potassium channels, leading to depolarization, and that leads to the excretion of insulin. This effect is independent of glucose, whether the patient is eating or not, whether there's a metabolic increase or not, it causes the insulin secretion. But it does require a functioning beta cell for its functioning. Next, please. In terms of benefits, yep, it does help with glucose reduction. It reduces both the basal and the prandial glucose levels, and it's got a good rapid onset of action. Bit more about the side effects. So weight gain, which obviously one thing we want to avoid in diabetes, there is some concerns of weight gain. With the second and third generation SUs, there is about a 5 kilogram weight loss over the many years, and also some weight loss noted in the first 6 months. There is a risk of hyperglycemia because the effect and the insulin secretion is all glucose independent. And some studies have shown that the hypoglycemia in patients with SUs was similar to patients with type 2 diabetes in the first 2 to 3 years of insulin treatment. In terms of reducing hypos, there is the glycoside modified release formulation, which has got the benefit of having the least or the lesser hypoglycemia effect. Because there's a glucose independent insulin secretion, it's important to remember that there is this potential risk of with prolonged use and with long durations of diabetes of leading to beta cell exhaustion, which will lead to disease progression and the need for insulin therapy. And a reminder, they should also be used in caution of patients with hepatic renal disease just to avoid and reduce the risk of hypoglycemia with it. Next slide, please. Next were the TZDs, or the thiazolidiones or glitazones, which came in the 1990s. These activate the PPAR, or the peroxisome proliferator activated gamma receptors. These are insulin sensitizers. They help improve the insulin sensitivity by upregulating the insulin receptors. By doing so, they increase the action of the insulin sensitive tissues, increasing glucose uptake and decreasing the hepatic glucose production. Next, please. Glitazones, they do take about 4 weeks to work. We do need to monitor liver functions, and NICE has given us guidance on reviewing the efficacy at 6 months. In terms of benefits, it does got some beneficial effect on improving lipid profile, and that it doesn't cause hypoglycemia. Next, please. Glitazones and side effects. Fluid retention is a possible side effect leading to weight gain, and it presents as peripheral edema. So it's really important for patients to observe for side effects. Heart failure is an absolute contraindication for its use, and it's also contraindicated in patients with macular edema because of risk of worsening of the condition. In terms of weight gain, it's about 1 to 4 kilograms in the first year. It can cause dilutional anemia. There is this increased risk of fracture in women with type 2 diabetes with long-term use. There were 2 types, rosiglitazone and pioglitazone. Rosiglitazone has been withdrawn since about 2010 because of the increased risk of cardiovascular disease with them, and currently pioglitazone is the only glitazone in use. Next, please. Going about 8 years ago, there were concerns raised about pioglitazone and bladder cancer. What they noted was that with a dose-related effect, with a higher dose of 45 milligrams, with a longer duration of use, and possibly more in elderly men, there was an increased risk of bladder cancer. But then there were some studies hadn't confirmed this. Parts of Europe had stopped using it and discontinued and withdrawn the use of pioglitazone. UK has continued, but it's important that we counsel patients of the risk. It is contraindicated in patients with bladder cancer or past history of bladder cancer, and in patients with uninvestigated microscopic and macroscopic hematuria. Yes, please. Sorry to see there's a lot of comments coming in. I Do you want me to pause for a second, or
No, Adil, I'll make a note of that. It's
okay.
a lot of them run in my comments. Sorry.
Oh, is it okay? I'll stay back.
I'm just putting a little bit of tips as we're going along. So apologies.
Glenoids, I can see something flashing, but I can't open it, unfortunately. So in terms of glenoids, these came in 90s, including repaglinide and itaglinoid, the ones we're aware of. They're similar to SUs in the sense that they are insulin secretagogues, similarly binding the potassium channels. They stimulate the first phase insulin secretion, so it helps with prandial insulin regulation. They're faster acting and they've got shorter duration of action. It's important to start low and titrate up so slowly. And again, there is some hypoglycemia and weight gain with them that we need to be aware of. Next, please. Acrobos, I've probably seen just 2 patients on it in my 15 years as a gypsy in diabetes. Haven't initiated any myself. They are very rarely used in the UK just because of its bothersome side effects of flatulence and diarrhea. But just a really quick reminder on them, they are the alpha glucosidase inhibitors. They inhibit the enzyme needed to digest carbohydrates, and so therefore they reduce postprandial glucose levels. Next, please. And next slide, please. Moving on to the other medications, the GLPs and DPP-4s, I just want to have a quick reminder of this incretin effect, the graphs on the left and right. Just a reminder that on the left is a patient who does not have diabetes, is a healthy patient. And what it shows is that when a patient, when the patient was given a oral glucose load orally, which is the black line, there's a greater insulin secretion compared to when they're given the same glucose load as IV glucose infusion. On the right, which is the patient with type 2 diabetes, again, there's a greater insulin secretion after an oral glucose load compared to intravenous, but this effect, this incretin effect, the difference in the both is both reduced and delayed. Next slide. This incretin effect is mediated by GIPs and GLP-1 hormones, which include glucagon-like peptide, GLP-1, and glucose-dependent insulotropic polypeptide. These account for about 2/3 of the insulin response to a meal. In response to a meal, when it gets to the intestine from the K cells and L cells, we get incretin hormones production and release. Next slide. Once they're secreted, the natural body's incretin hormones are rapidly broken down by the DPP-4 enzyme, and then the remaining active molecules then stimulate and promote glucose-dependent insulin secretion, and they suppress glucagon secretion. And by doing so, they help with the blood glucose control. Next slide. In type 2 diabetes, looking at GLP-1, GLP-1 levels are reduced, but the effect is maintained. I haven't brought GIPs. GIPs have got, the levels are abnormal, but the effect is reduced. Next slide, please. So increasing the GLP levels in these patients, what can we do? We've got one option of actually giving a GLP-1 agonist, or the other option is giving a DPP-4 inhibitor. Next slide. GLP-1 agonists, how do they work? They've got a lot of functions. On the pancreas, they can help increase glucose-dependent insulin secretion, and they reduce glucagon secretion. By doing so, they help with the glucose homeostasis. And there's some thoughts of preserving beta cell function by increasing beta cell mass, reducing beta cell apoptosis, and increasing beta cell neogenesis. They also act centrally and in the stomach to help with weight loss. Centrally, they induce a feeling of satiety, and they reduce reduce appetite by reducing oral intake and promoting weight loss. And similarly in the stomach, by reducing gastric emptying, again giving a feeling of fullness and supporting weight loss. In cardiac, there's some thoughts of slight increase in improved left ventricular function after a myocardial event. Next slide, please. GLP-1 agonists are generally given subcutaneous. There are several options. The first ones were the twice-a-day exenatide that came in around 2007, which were found from the saliva of Glea monster with about a 50% homology with a human GLP-1. Then were the once-a-day liraglutide, which is a modified form of human GLP. And now there's several options with once a week options that include exenatide, dulaglutide, and semaglutide. Next slide. They do need a functioning beta cell. There's no hyperglycemia as they're glucose dependent, but they support weight loss. I tell patients side effects, there are initial some side effects, and I do tell patients that, look, this is a normal gut hormone that we have. So it is GI related side effects that they will experience: nausea, vomiting, diarrhea, dyspepsia, headache, and starting low dose, letting the patient settling with the symptoms, and then increasing dose means there's better compliance and they manage symptoms better. There is the rare risk of pancreatitis. It's important that we counsel patients about the signs and symptoms for them to seek urgent medical attention. With the liraglutide, there were some reports of thyroid cancer in rat models. So it's a generally good practice that we do examine the thyroid gland at the time of initiation, and it's documented in the notes. Next slide, please. Because of cost, these were initially quite expensive. NICE were quite strong about the guidance with a BMI of 35 or a lower BMI in patients with BME origin or patients where weight loss will help other conditions like sleep apnea or other conditions. And also there's guidance on reviewing the efficacy at 6 months and at 1 year. Next slide, please. So one option is giving the GLP-1 agonist. The other option is inhibiting the enzyme involved in the breakdown of the natural GLP, the DPP-4 inhibitor. Next slide. DPP-4 inhibitors are the enzyme dipeptidyl peptidase 4 inhibitors. They inhibit the breakdown of endogenous GLP-1. When compared to GLP, the levels of GLP are lower after a DPP-4 compared to a GLP agonist. There is lower glucose lowering, but there is less side effects compared to GLP-1 agonists. Next, please. They're given orally. There's no increase in hyperglycemia. They're weight neutral. I'm sure forgetting one gliptin around, you remind me, but there is Sita, Wilda, and Saxon linagliptin. Wildagliptin is twice a day, needs liver function monitoring. The rest are once a day. With sitagliptin and saxagliptin, there are renal doses available. So with reducing eGFR, the dose needs to be adjusted. With linagliptin, it's a single dose, can be used till end-stage renal failure. Next slide, please. The new medications on the block, or the medication you're probably hearing a lot about, are the sodium glucose co-transporter 2 inhibitors, SGLT2. They work by blocking the reabsorption of glucose and sodium from the renal tubules, with resulting in urinary glucose excretion. They help reduce glucose level. They help cause weight loss. In terms of side effects, GU symptoms are common and patients need to be counseled about it. They do present with some symptoms of thrush and cystitis. These can be reduced and managed better with hygiene and generally cleaning after passing urine. With the glucose, water can follow it. So there's a risk of dehydration. So it's important the patients are reminded of hydration. I'm going to come back to ketoacidosis in the next slide. Again, during severe diarrhea, vomiting, and the patients not eating, the poor intake, it's important that patients hold on the medication. And Fournier's gangrene, I can come back to as well. Next slide. With SGLT2 inhibitors, there is the possible increased risk of ketoacidosis. And in a third of these patients, it is what we call euglycemic ketoacidosis, where the patients have a normal or only a slightly raised glycemic level. In terms of ketoacidosis, some predisposing factors are excessive alcohol use, illicit drug, very low carb ketogenic diet, pregnancy, patient with LADA. So it's important that we do start in a patient appropriately. What can precipitate the ketoacidosis is increased risk with dehydration, with severe vomiting, prolonged exercise, and an acute illness. And it's important that patients are informed of the signs and symptoms of ketoacidosis to be aware of. Next, please. Next slide. Fourniers gangrene, there is a MRHA alert being raised on SGLT2s and Fourniers gangrene. CQC are really hot on this. They do want at every consultation, we do document it clearly that Fourniers gangrene risk has been discussed. But it is important that we do tell the patient that, look, this risk is rare, but they need to be aware about it. It's more common, it's commoner in males than females. And patients need to be advised to observe and seek urgent medical attention if they notice any severe pain, tenderness, erythema, swelling in the genital or perianal area with associated femur and malaise. And the medication, and they seek urgent medical attention, and the medication is stopped. Next slide, please. The current SGLT2s that we have, we got canagliflozin, which is recommended to be started at 100 milligrams, and the dose can be increased to 300 milligrams, depending on how they're tolerating and the response. Should be taken before breakfast. Dapagliflozin comes as only single dose of 10 milligrams in patients with type 2 diabetes. Empagliflozin is recommended as starting dose of 10, which then can be increased to 25. Ertugliflozin is a 5 milligram starting dose that can be increased to 15 and taken in the morning. Next slide, please. Renal function and SGLT2 is really important. Recently, DAPA has got a license up to an eGFR of 25. However, at the lower GFRs, the glycemic benefit is reduced. With regards to canagliflozin, if the eGFR is between 45 to 60, it should be initiated at 100 and maintained at that dose. Once the eGFR drops, if the eGFR is below 30 to 40 and between 30 and 45, and they have an ACR ratio of greater than 300, it should be initiated at 100 and maintained at the dose. And if the eGFR is less than 30, then the medication should be stopped, should not be initiated. In terms of empagliflozin, it can be started if the eGFR is greater than 60, and if the patients are tolerating it well and the eGFR drops below 60, then the dose should be adjusted to just a 10 milligram dose. And if the eGFR falls below 45, this should be stopped and discontinued. Next slide, please. And finally, comparing SGLT2 to the other medications, looking at SGLT2s were more effective than placebo for HbA1c and weight reduction. When compared to gliptins or DPP-4 and sitagliptins, they were more effective, and there was more weight loss and better weight change based. Compared to sulfonylureas, probably similarly effective in HbA1c, but they were more effective in weight loss. And finally, compared to pioglitazones, again, they was more effective with weight change. Next slide, please. And just one or two slides touching on insulin. Next slide. Reminder that type 2 diabetes is a progressive condition. There will be progressive decline in beta cell function with a gradual reduction in serum insulin. Next slide. Next slide, please. And so as diabetes progresses, patients will need insulin to optimize their glucose control, and other agents have failed to achieve control. Next slide. Just a quick reminder that insulin was discovered in 1920s by Banting and Best. The initial insulins were the animal insulins, then the human insulin, and then analogs. And this can be given as short-acting, long, intermediate, and mixed insulin. Next, please. Insulin can be effective, is effective in reducing glucose control, but insulin can cause weight gain. And as the weight increases, the body's body mass increases. There's an increased abdominal obesity. With that reminder that as the weight goes up, there's increased insulin resistance, and so patients will gradually need more insulin and requirements with time. And also a reminder that there is a risk of hyperglycemia with insulin. Next, please. Insulin type 2 is often started when there is severe hyperglycemia at times of presentation diagnosis, when there's a poor glycemic control with osmotic symptoms, when the patients are unwell with sepsis during pregnancy and other agents have not been safe, for example, severe renal impairment or after an MI. Next, please. Just finishing off with just a reminder of the 6-day rules. If the patient have got coronavirus or any other illnesses, these can impact on blood glucose levels. If the patients have a glucose meter, they should be reminded that monitor the sugars more frequently, or if they haven't, they should be educated of the signs and symptoms of hyperglycemia. Patients should be advised to keep hydrated, not too fast. I'll come back to the medications on the next slide. And also to seek when to seek medical attention if they're not cannot maintain hydration. Important that patients don't stop the insulin, because actually the dose will need adjusting. Oral medications with dehydration, there is a risk of lactic acidosis with metformin, so this will need to be held off. With SUs and clinoids, just a reminder of when they're unable to eat or drink, there will be an increased risk of hypos. With GLP-1s, again, with dehydration can increase serious side effects risk. And SGLT2s, important that with dehydration, reminding patients they're more likely to have the ketoacidosis and so to hold off the medication. Next, please.
Can people please mute themselves, or can you help, please, Temi? Just mute people, thank you.
This is where Imran's going to help us out. Which medications? Yes, it does kind of be shouting, screaming, and can confuse what to do, but there is guidance. There's nice guidance. There's local guidance, patient's clinician choice, and also preference. Next slide, please. And just a summary. Thank you. That was just a quick list top of all the tablets.
No, excellent, Adil. Thank you ever so much. That was really, really well explained. I've just put a little note in the chat function, which I forgot. I always forget something or the other at these meetings. Can you please, all the additional roles, because we may have some funding for the PCNs to allow you to come here. So kindly, please just put your PCN and names here. Right, Imran.
Okay, thank you.
The floor
That
is
was
yours.
brilliant, Adil. Thank you very much. So we're just going to have a quick look at the local guidelines, and then we're going to hopefully make a very interactive session with 4 very simple case studies, he says, just to whet your appetite and get you ready for those lovely people with diabetes. Okay, we got the slides up. Thank you. Jyoti, you mentioned about LADA. So LADA is usually, although not always, patients who've got BMI of less than 20. Okay, they're usually quite thin, and they will present with, they can be very symptomatic of osmotic symptoms. You would almost be possibly looking like a type 1, but they're not type 1. And if you're not sure, if you've got somebody who's quite thin, very symptomatic, very high HbA1c at diagnosis, don't be afraid to send off some GAD antibodies, okay, blood test. And these days, when you send to BH to our local lab, they will also do some other antibodies at the same time. They do the 3 now for you. And if they come back as GAD positive, then you can be quite sure that they are LADA. The treatment is the same as a type 2. You will start off with metformin. And yes, that's right, it's triple antibody now. So even if you just put GAD, they will do the triple. And the thing is, though, they will progress to insulin usually within 6 to 12 months. So even though you're starting off on metformin and things, the progression to insulin is quite quick. So if you do get a confirmed diagnosis of LADA, it's important to have that discussion straight away with the patient, because what you don't want is hesitancy. No, I don't want to use an injection. And we know that happens. So if we prepare the patient, you don't have to scare them. You just have to say, look, we're going to start off with tablets, but invariably, some patients do end up on insulin, and this may be the case, and you don't need to be scared when that happens. We are here to support you. We will help you, and the needles are not this big anymore. They're only tiny, so you'll be fine. Okay, right, next slide. So local guidance is, national, nice guidance. There's been some changes. regarding the cardiovascular risk factors and the chronic kidney disease risk factors and the heart failure risk factors. Next slide. So most of you will be aware there's been a lot of clinical trials, okay? when a new drug is released, you have to prove it's not going to adversely affect your heart. So now this all stems back to rosiglitazone. So when they did the trials for SGLT2s and some of the newer GLPs, what they actually found was the opposite was happening. They actually had a fantastic cardiovascular outcome, you know, less admissions for HF, you know, less MI, less stroke. So with all that overwhelming evidence, NICE has had to go back and have a look at the existing guidelines and update it in light of the new evidence. So this is the new NICE guidelines. And as you can see, what it says is still metformin first line, but then it gets a little bit more nuanced after that. And what I've done is I've broken down this quite complicated looking guideline and break it down into step by step. So next slide. Now, what it says is if a patient has established cardiovascular disease or heart failure, right? So established cardiovascular, they've had a heart attack already, they've got angina, they've got ischemic heart disease, they've got peripheral arterial disease. So we have that diagnosis. You start off with metformin, or if they can't tolerate metformin MR, and you add, here we go, you add an SGLT2 at the same time, or a couple of weeks after you start the metformin to see it's tolerated. This is dual therapy at diagnosis. You've not done that before, have you? You normally do metformin, then you add one, then you add one. Here you start off with two, with a 2-week gap, just to make sure the metformin is okay. Next slide. Right, now, if they're high risk of CVD, so let's say they've got a Q risk of 10% or more, then it says consider adding an SGLT2 inhibitor. I'm just going to sorry about that. What does this mean, consider? It doesn't mean you must add. Look at the patient circumstance, look at what risk they've got. And if you feel they will benefit from an SGLT2 inhibitor, you can add it on as well, but it's not a must. And that's the difference. So established, add SGLT2. If it's high risk, Q risk more than 10%, consider it, think about it, see if it's the best interest of that patient. Next slide. Okay, if those of you that attended the CKD event yesterday, by now this is imprinted on your brain and you will be dreaming of this slide forever and ever. But basically this is about chronic kidney disease and establishing which patients have chronic kidney disease and which don't. Traditionally, I'm going to show my age. Back in the day, you'd send off for an EGFR, it would say greater than 60, and you said, you wiped your hands, you said, this is lovely, no problem, go away. But of course, we now know that's not as simple as that. If they have urine ACR of more than 3 in diabetes, that is a problem, okay? So this is why this table is important, to bring it to your attention that this patient has CKD. So you diagnose the CKD. Next slide. So what are the implications then of SGLT2s and management of diabetes with CKD? So if the ACR is more than 3, what does that mean? Well, Adil has already mentioned about SGLT2s and their licensing in chronic kidney disease. Now, dapagliflozin has been licensed and NICE TA'd for chronic kidney disease. And basically what it says is, if a patient has chronic kidney disease, maximize your ACE-ARB to the maximum tolerated dose that the patient can handle. And then if the urine ACR is more than 30, you will give an SGLT2. And if it's more than 3, you will consider giving an SGLT2. So dapagliflozin is licensed in type 2 diabetes if the eGFR is between 25 and 75 with the urine ACRs I've just told you, or even if they've just got CKD, it has been like nice TA'd for if you have a urine ACR of more than 22.6, which was an average number they derived from the trials. Next slide. Right, so I've already told you this. So remember, above 3, consider. Above 30, offer. So just like in the coronary vascular disease, consider an offer. Yeah, next slide. So the only licensed one at the moment is dapagliflozin. It is not licensed under eGFR of 15, but do not start dapagliflozin with an eGFR of less than 25. Okay, so start at 25 plus, but it can go down to 15. And then if it does go down to 15, then you stop. Next slide. So what NICE is saying is, you may have a patient who was completely fine. You started them off at metformin, and then, you know, a year or two later, you know, the HbA1c is not controlled. You decided, you know what, I'm going to give them some sitagliptin. They're now on metformin and sitagliptin, and then all of a sudden, their Q risk has gone above 10%. So what NICE is saying, at that stage, you need to add in or consider adding in an SGLT2 or switching maybe the DPP4 for an SGLT2. It depends, yeah, depending on that individual circumstance. If during that time they've developed, let's say, chronic heart failure, or they've had a CVD event, or they've developed PAD, then again, you would add in an SGLT2 inhibitor or swap one of the existing drugs for an SGLT2 inhibitor, depending on that patient's individual circumstance at the time. So in other words, here's the take-home message. If you have coronary vascular disease, if you have chronic kidney disease, if you have heart failure, we need to have an SGLT2 in there somewhere in their treatment, as long as it's tolerated. Okay, obviously if they can't take it, they can't take it. But the idea is to put them on it. Next slide. Right, rescue therapy. So, you know, you've got these patients coming in with very high HbA1c. They're very asymptomatic, you know, they're you know, struggling with it. So you've got two options. You can either do insulin, which I know we're not going to do in primary care, let's be honest, or you can give an SU. Now, when it comes to the SU, next slide, there's 3 SUs, which I would say are, I would recommend that we prescribe. One is gliclazide, one is gliclazide modified release. The other one I've not written on there, but the other one is glimepiride. These are 2nd, 3rd generation SUs. They have less hypo risk than the older ones. Okay. My personal go-to, but this is personal, you can do whatever you want. My personal is to go with either gliclazide 40 milligram or gliclazide MR 30 milligram. Again, this is a personal thing. I tell them you must take it just before your breakfast, okay? And you must have your breakfast after that to reduce the risk of hypos. If you're skipping your breakfast, you're skipping meals, skip the tablet. And, you know, touch wood, the number of hypos that I've had to record, 1 in the last 5 years, okay? 1 in the last 5 years. And at those low doses, trust me, you're not getting much weight gain either. I don't think I've seen any of my patients who are on 40 milligrams and 30 milligrams of gliclazide get any weight gain. So I don't use high doses of gliclazide at all. Anybody who's using 320 milligrams of gliclazide, you know, you're wasting your time. If 40 hasn't done it or 30 hasn't done it, trust me, higher doses are not going to do it. This works just fine. And you reduce all your risks. Next slide. So for heart failure, we know that DAPA has now got a license, and EMPA, the results from the EMPA trials have been fantastic as well. So these are now licensed also for the treatment of heart failure. And again, as add-on to ACE, ARB or beta blockers, and spironolactone, or the new one, the sacubitril and valsartan. So this is just for information. I expect these will be started more by the specialists, but when you see the discharge letter and you see, empagliflozin or dapagliflozin on there, and you're thinking, hang on a second, why have they done that? This is the reason. They're using it for the heart failure, not for the diabetes. They might not even be diabetic. Okay, so don't be alarmed. Next slide. Okay, so the local guideline, which we involved everybody, because everybody likes to be involved. It's a nice party to come to. So we produced our local guideline, which, to be honest with you, is just the nice guideline, but ours is much prettier. It's got much nicer colors. So if we can go on to the next slide, and it combines the CKD as well as the CVD, which NICE didn't do. So in the blue, this is your typical no CVD, no HF, no CKD, and that's exactly what you've been doing already. Start metformin, add a drug, all of that. For established CVD, again, it's adding in that SGLT2. So start metformin, wait a couple of weeks, make sure metformin is tolerated, then add in your SGLT2 inhibitor, okay? Same for the HF, same for the CKD. And then after, you can add in your DPP4 or whatever it is you're going to add, okay? And then if they haven't worked, you can then go to a GLP. Just remember one thing. If you're going for a GLP and they're on a DPP4, stop the DPP4, all right? The difference between the two is this. DPP4 preserves your physiological amount of GLP. Yeah, what your body's producing, it preserves it. The GLP is a pharmacological dose of GLP. It's far more than your body produces. It's a much bigger hit, which is why you tend to get better results, but also ultimately, sometimes, unfortunately, more side effects. And I'm going to give you some news now. You heard it first at the CK Diabetes Workshop. There is a new drug coming. It'll be either next year or early 2024. It is a GIP GLP combination, and it has so far in trials had massive weight reductions and massive reductions in HbA1c. So watch this space, that is coming. Next slide. Okay, now the fun bit. And this is where I don't mind if Dr. Sood allows me to let you unmute yourselves, shout out what you think, and I really have no objections. So let's have a look at this chap. 42-year-old Pakistani male, BMI is 28, hypertensive. He's got a new diagnosis, HbA1c is 88. He's thirsty, tired, passing urine frequently, he's losing weight, strong family history, mother, father type 2, father had a heart attack and a stroke, mother is on insulin, siblings all got diabetes, and prior to his diagnosis, his Q risk was 6.2%. His last blood test showed an eGFR of more than 90, cholesterol of 5.2 with a ratio of 3.3, triglycerides 3.3, and just for clarity, fasting. ALT is 78. He's a bus driver, doesn't drink, doesn't smoke. Blood pressure was 143/84. and lisinopril 20 milligrams is what he's on. So what are you going to do?
Has he got
I've seen metformin.
ketoacidosis at all?
Sorry,
Have
you asked them to all speak up.
Sorry.
Sorry, say that again.
Have we, I mean, considered ketoacidosis in this patient?
He's not ketotic. I can tell you that now. I dipped him. No ketosis. No HSS. No ketosis. He's got no abdo pain. He's not nauseous, not vomiting, no sweet smell, nothing like that.
So Imran, we've got a couple of responses. Metformin.
ACR, yes,
ACR.
we can do.
Yeah.
Yes, absolutely. We will definitely be doing a urine ACR. Let's, for the sake of this, ACR is negligible. It's less than 3. And obviously metformin, of course, we would start metformin. Any thoughts on those blood test results? We Q-risked him again, Dr. Ola, and it's about 14% now.
Yeah, so
Yes,
we'll
lifestyle advice, absolutely.
lifestyle, statins, Q-risk is more than 10. So statins, they're diabetic
Yep,
now.
so he's going to need a statin.
And then the
so
blood
all the
pressure.
medicine. Yes, oh my goodness. Is that Andrew? Yes, you're really going for him, aren't you? You're gonna give him a whole carrier bag full of medicines. Yes, but you're right. Statin, metformin, lisinopril to be increased. All right, why has he got a raised ALT? Anybody?
Well done. Well done. Margaret, go. Do you want to say? Yeah, well done.
Go.
Fatty liver?
Probably. I mean, we can't rule out other pathology behind that liver result, but often you can see from the baseline, you see, 1 minute it was 41, then it's jumped up to 78. They're not jaundiced, they haven't got any other symptoms, motions, normal color, all that kind of stuff. So more than likely fatty liver. I would say it is fatty liver. If you're not sure, send off for some liver screen, but more than likely it is fatty liver. And what do those triglycerides tell you? Anybody?
I think it's low, actually. It's not bad.
It was a fast. This chap listened to me and actually went fasting. So what do you think? What's the normal range? Anybody know off the top of their head? Up to what, about 1.7, 1.8? So we have got some raised triglyceride there, assuming that he genuinely was fasting at the blood test. Now, you can have raised triglyceride because you've got high HbA1c, that can be causing it, but it can also go the other way. Raised triglyceride could be causing insulin resistance, and therefore you're getting that high HbA1c. Find out about his diet. Has he got a high fatty food, high, kebab roll every day, that kind of diet, that could be, yes. So, yeah, so absolutely check the thyroid function test as well. You can do the Hep B screen and Hep C screen and the liver screen. But let's assume for this instance, it is actually fatty liver. And that will explain a lot of things. Now, if he's got fatty liver, that's going to be linked with hepatic insulin resistance. Remember, this chap's got a BMI of 28. There's going to be a lot of systemic insulin resistance going on as well. And therefore, we need to tackle that insulin resistant. Metformin is absolutely, that's a given. We will do that. Statin, absolutely a given. We will do that. Is there anything else you would add into this very symptomatic patient?
In the past, before the SGLT2, I would have started him on insulin.
Right. Yes, absolutely. You can. If you are able to, you can do insulin for rescue. And Amish hit the nail on the head as well. Gliclazide. How many of you, I mean, if if you're in this situation, you think about it. He needs a bit of rescue treatment. He's got a HbA1c of 88. And honestly, 40 milligrams of gliclazide pre-breakfast for 3 months and then review is often enough. You might need to do it for 6 months, but often 3 months is enough. Now, according to the new NICE guidelines, we can also, remember his Q risk is now 14% post-diagnosis, we can consider what drug? Anybody? What can we consider also? Yes, absolutely. Yeah, so we could consider an SGLT2. Now, who's going to give him an SGLT2, gliclazide, statin, metformin, and increase the dose of his lisinopril? Anybody brave enough to do all of that? I'm not. I'll be honest with you, I'm not that brave. He's symptomatic, and this is where NICE guidelines is a guideline, all right? And this is where we need to think beyond guideline. And this is why I wanted to do these case studies. So this chap is asymptomatic, he needs some rescue treatment. I don't want to overload him with all of these drugs. Also, by adding in gliclazide, SGLT2, and metformin, there's risk of hypo. What does he do? He's a bus driver, right? So I would, and this is only what I would, other people may do different. I would start him on his metformin. I would give him 3 months of gliclazide to try and get it down as much as I can. I would stop it. I would then add the SGLT2 inhibitor. I will also start the statin. By the way, can I start a statin with an ALT of 78? Yes or no? Is there anything you should be worried?
It's not very high.
Yes, exactly. It's to, as long as it's less than 3 times the upper limit of normal, you can start a statin, not a problem. Okay. Exactly, yes, times 3, absolutely. So 3 times 42, but monitor, yes, absolutely. We're going to repeat the LFTs in how many months? 1, 2, 3, 4. How many months we're going to repeat? That's it.
3 months.
3 months. We're going to, we're going to repeat the LFTs in 3 months, and we're going to repeat the cholesterol in 3 months to make sure we're getting that 40% reduction in the LDL. Brilliant. You don't need me. I won't bother with the other 3 case studies. I'm going. I'm only joking. Right, case study 2. Next slide, please. Right, here we have a female, Caucasian, 77, BMI 22, hypertensive, COPD, AF, CKD, type 2, smoker less than 5 a day, peripheral artery disease, not much going on. So a simple patient. Latest blood test showed a blood pressure quite decent actually, 127/63. EGFR's dropped in the last 8-9 months from 33 to 29. Not a big drop. Urine ACR is 77, but that has increased. It was 8 last time. Cholesterol's reasonable, 4.1. HbA1c 88, has gone up from 64. Some retinopathy in the left eye, no maculopathy. The patient does have a active foot ulcer being treated by the foot clinic. They're on apixaban, ramipril, amlodipine, metformin, linagliptin, glimepiride, salbutamol, Braltas, Symbicort, atorvastatin. Now, we have these patients, don't we, in our surgeries? I mean, this is not something which is atypical, right? Dr. Ola, stop the metformin. Let's get a creatinine clearance check done. Yes, we can do that because they're on apixaban. What else?
After he started
DAPA.
smoking.
Okay. Somebody, Binesh, you've put Hema, you've put insulin, and somebody's put Binesh put dapagliflozin. Does it meet the criteria? The EGFR is between 25 and 75, tick.
Yeah.
UACR is above 3, tick. What? Who wouldn't give dapagliflozin? Okay, so which particular comorbidities might you be worried about? Foot issues. Yes, possibly. Yes, and peripheral artery disease as well. Yes. Now, again, I'm not going to tell you what to do, what not to do. This is just to highlight the things that we need to be looking at. And I think I heard your lovely voice saying yes. Did I, or am I mistaken? Gone silent. Who said they would give DAPA? Doesn't matter. Who? Right. You would. Okay, and that is a clinical decision. I would say, me personally, I would be, EGFR is 29, right? I would be a bit cautious because of the active foot disease. And because they've got peripheral artery disease as well, and they're 77 years old. So if I did stop the metformin, and I think it was Dr. Gerida who said insulin, for me personally, but this is just a personal choice, I think insulin could very well be a good option in this patient. However, that's not to say don't give the dapagliflozin if that's the way you want to go. Jyoti, I'm A&Ging you now. What's your opinion?
I'd agree, Imran. I mean, I think the BMI is 22. They've got plenty of risk factors. So if we can control it, and in my experience as well with the HbA1c, and if you see most of the trials, they do cause a drop up to about 5% of HbA1c, but that still won't take it us to target. So I don't think DAPA on its own is going to bring it down. They will need something else.
Okay, excellent. Brilliant. So you see, the thing with these case studies is it's not what's right, what's wrong. It's food for thought. It's to make us think what we can add DAPA along with insulin. You can, but you need to be careful, because with the DAPA and the insulin, then you have to, the risk of acidosis just slightly, ketoacidosis just slightly increases a little bit. So, but again, it's not that you can't do it, you can do it. But this is why these case studies, it's not right, wrong. It's about making you think about what to do for a particular patient. And it just demonstrates guidelines are lovely, beautiful, but they don't always fit every single patient. And we need to think about that patient and use the guidelines as that, as a guide of what to do. Case study 3, next slide, please. Thank you. Here we have a male Sri Lankan, 56-year-old, type 2, hypertensive, BMI is 39. They have CKD. At their annual review, they had retinopathy, mild retinopathy in both eyes. Blood pressure is 138/86. HbA1c has gone up from 68 to 76. EGFR, slight drop, 66 to 62. Urine ACR, slight increase, 14 to 22. Cholesterol is quite high, 6.2 with a ratio of 4.4. Last year it was 5.2. So taxi driver, never smoked, drinks a little bit. Foot check, nothing, no problems. Usually has quite a high carbohydrate diet, but all his friends have told him to go keto because they've lost weight, and apparently it's helped their blood glucose control. He's currently on a Atorva 20, but the EMIS, the computer says he is not really ordering it that often. Ramipril, amlodipine, sitagliptin, metformin, dapagliflozin. Again, the records indicate not really ordering it that often. He was on pioglitazone in the past, and he was on gliclazide in the past. When we sit down with him and we say, listen, you're taking your medicines? Yes, I am 100%, I take them exactly as you prescribed them. Okay, no problem. Do you ever miss any? I mean, like, even I take medicine, I forget. What about you? Yes, obviously, sometimes you forget. So any problems with the medicine? What about the new one, the dapagliflozin? How are you getting on with that? Oh, I go, we all the time. I'm stuck in the taxi. Is that causing you a problem? Just be honest, is it causing you a problem? Yes, I can't take it because make me go wee all the time. When you're driving, it's not good. So that's the conversation that's happened. Hema has come up already with a suggestion, GLP agonist. Anybody else, what would you like to do? Any advice you can give this chap? Should we persist with the DAPA? What do we do? Yes, compliance is the issue. Yep, so GLP-1 or exenatide, yes. So exenatide is also a GLP-1, yes. Anybody else? Stop drinking alcohol. Well, I think we can give alcohol advice and say you can cut down on the alcohol, probably not helping. And don't forget, with lots of alcohol and the DAPA, you have got increased risk of ketoacidosis. So we want to give that advice anyway. Anybody else? Got some good suggestions, some really good suggestions in. Jyoti, can you read them out? Yeah, good choice. GLP is a good choice.
I think
BMI is
GLP,
high.
yeah.
Everybody's going for a GLP. You know what? Yeah, exactly. Taxi driver, just like us, sat at desks, no exercise.
I think
Stop
Kanika's made a
DAPA, trying
point.
keto diet. Yes, yes,
Kanika's made a
absolutely. He
point
wants to
about
go on the
keto diet. Yeah.
Yeah,
Well done,
yeah,
Kanika.
absolutely. Yes, exactly. And do we want to dissuade him from having a keto diet or a low carb diet? Personally, I don't have an objection to it. Does anybody have an objection? If we were to stop the dapagliflozin, because he's not taking it, and we add in a GLP, who wants to add in which GLP? Any personal preferences, Ed? Would any particular GLP be better or worse than any other? Ozempic, well, lovely. Yeah, liraglutide, Ozempic.
Where the reps have been around, eh?
Yeah, no, they're doing a good job.
But I think Bimesha said, weekly, which makes sense. So I think it's
Yes,
probably to stick
absolutely.
to a weekly.
I would agree. I think if you, from a compliance issue, if you sit down with a patient and say you've got to take an injection every day versus you've got to take an injection once a week wins every single time. Ozempic, I will hurry this on because we're going over time and I talk too much. But Ozempic, the only thing I would say to you is they've got mild retinopathy. And with mild retinopathy, if you're not sure, do an ANG to endocrine. And I already know what the answer is, by the way. The answer is going to be, we don't mind, carry on. So keto diet if he's got a high protein, we need to counsel them on that. Yes, Ozempic is slow titration, 0.25, 0.5. But yeah, Ozempic you can give. If they had moderate, severe retinopathy, I would be more cautious and I might go for something like Trulicity. But with R1, I don't see too much of a problem. But if you're apprehensive, just tell the patient to phone the retinal screening people, tell them that he's gone on to that drug. And if they can just do a screen a little bit earlier than they would have done, that's absolutely fine and that's absolutely acceptable. Next slide. And this is the last one, I promise. Right, female, 31, BMI 38, Afro-Caribbean, actually from, let's say, from Ghana, okay? Presented at A&E unwell, symptoms of DKA. They followed the DKA protocol. Hospital initiated insulin, discharged, no other meds. On your discharge letter from 3 years ago, it says the diagnosis was diabetes. They're on Levemir, 32 units of bedtime, Nova Rapid. They've had in the last three months, 3 hypos during the night. Their blood glucose go up, down, all over the place. The latest HbA1c is 102. The patient has a BMI of 38. The patient is extremely depressed about this blood glucose control. They're tearful because they don't understand why things are so bad, and she's trying, you know, she's trying to do all the things that you tell them to do. They're still tired all the time. EGF 88, urine ACR slightly raised 3.2, blood pressure is 138/94. How do you deal with this one? I will rate the first person who tells me anything on this one, because this one is a nightmare. Anybody? Jyoti, anything in the comments?
Very
Check
good.
diagnosis.
Yeah, check diagnosis, Amish. Well done.
Who said check diagnosis?
Amish.
Amish, there is a, Dr. Sood will send you a Mars bar gift in the post. 'Cause I
Mars
can't
bar.
afford it. Absolutely, it's a diabetes session. We'll do a Mars bar. Who agrees with check diagnosis? And why would we be checking the diagnosis? Why do I need to check the diagnosis? Well, it doesn't say, does it? Does it say type 1? No. Does it say type 2? No. Just says diabetes. Could be monogenic. Could be monogenic. What else could it be? What else could it be? And by the way, this is not made up exactly. That diagnosis of diabetes was actually on the discharge letter of a patient that I was dealing with. And Hema Works is one of my lovely colleague GPs, and she may remember, or possibly this patient, just says diabetes. Yeah, exactly. So we don't know whether they're type 1 or type 2. They were just discharged on insulin. But they were treated for ketoacidosis. They had ketoacidosis. Ketoacidosis is quite rare in type 2s. HHS is more common in type 2s. Very similar, but not the same.
Diabetes.
So somebody said LADA. Somebody said LADA. So latent autoimmune diabetes adult, as I said, usually the thinner patient, BMI less than 20, it doesn't have to be, but usually is. This patient has BMI of 38. So I'm going to tell you a little treat now to end this session. There is something called ketosis prone diabetes. It's also known as flatbush diabetes. It was first uncovered in New York. The area of New York where the patients were pitching up from was, believe it or not, called Flatbush. It's an area of higher deprivation and a large African-American community. And what they found was that these patients were pitching up with ketosis, but they were not your typical type 1. And what it is, there is a type of diabetes more prevalent, not exclusive, but more prevalent in Afro-Caribbean, African-American, and these patients have a propensity to produce ketones. They suffer with DKA, but actually they're ketosis prone diabetic, and you need to treat them with metformin. And usually they start off on that insulin, and then once they've sussed out the diagnosis, they stop the insulin and they actually treat them with metformin and follow the normal course. Yes, it's a very atypical type, but this was just to highlight some of the things that do present, and we need to think sometimes, okay, this doesn't make sense to me, and it's something like this. And now that we've done it, you see, you'll all have this condition in your heads, and you'll be thinking, yes, there is something called ketosis prone or flatbush diabetes, and you heard it here on the C-pin. So another feather in our cap. That's it from me. I think they've probably had enough to.
Amazing, Imran. I thought half the room would be empty, but it's not. So fantastic, very well done. And a big thanks to all that have participated, and the interactive comments. Absolutely amazing. So I do hope you've enjoyed the session today. The plan, just to remind people, is that you have this sort of theoretical bit, so to speak. And those people that require competency sign-off, we are developing competencies for signing, particularly the additional roles. Obviously, a lot of people might be experienced, you don't need that. But for those people that feel they want to just develop that extra bit, they can have a case-based discussion or be observed. We've got the education leads that'll be supporting those competency sign-offs. So that will be the next step, and also the MDT faculty development, where we'll bring all the chronic diseases. So you'll have a patient with hypertension, diabetes, and COPD, and then we discuss
Jyoti, sorry, I forgot to mention one thing. If you suspect ketosis prone diabetes, send off for GAD antibodies. If they come back negative, it's ketosis prone. Sorry, I forgot that bit.
No.
So that's how you differentiate.
Do you want to type that, just so people that are busy typing the comments, because I think that's a key crucial bit as well. I just want to thank Adil, Said, and Imran. Absolutely fantastic. Thank you for all the hard work you've done on the slides. Absolutely brilliant. What I would like is, do you want to, Temi, do you have a feedback form here, or would that be through Eventbrite?
No, I just put it in the chat. So if everyone can send it in for me, please.
So
Before you go, when you have time.
Yeah, please, can we have feedback? It'll be absolutely excellent, I'm sure, but just in relation to the contents, etc.